Hey, good morning. Just had my cup of coffee, so I'm ready to go. Okay, so I know you guys talked a little bit about bacterial meningitis earlier today. I will say this topic that I'm going to be talking about today will not cover patients under the age of 2 months. It's really going to be primarily focused on the non-neonatal population. So hopefully this is helpful. Okay, so let's talk a little bit about meningitis. Bacterial meningitis, as we know, is something that we all talk about. It's a really sort of high-risk diagnostic challenge for us. And a huge part of the reason why it's such a non-easy diagnosis or tough diagnosis to make is because of the fantastic vaccination rates, although they've been faltering recently. But vaccination rates have significantly reduced the rates of meningitis, particularly the pneumococcal vaccine, the meningococcal vaccine, and the Hib vaccine. Because it's so rare, it's estimated, and this is sort of a generous estimate, that most of us in the ER who are honestly pretty much at the center of who's going to be evaluating meningitis. Anybody with any suspicion for meningitis, the first stop they're going to do is go to the ER. So you guys have to know this disease probably better than anybody else in the medical field right now. But it's estimated that you guys will maybe see a case of bacterial meningitis, one case every potentially 3 to 5 years, if that's the case. Which makes it even harder because a lot of our job is pattern recognition, and what makes us good at our job is saying, I've seen this present in 3 different ways, but I know that this is how it presents. So that's one of the tough things. So the incidence of bacterial meningitis has declined about greater than 50% from 1998, particularly, to mention one specific one, with the introduction of the pneumococcal vaccine. I think it was around 98 or 97 is when the pneumococcal vaccine was introduced. They started off with the 7-valent, which covered 7 strains of the pneumococcus, and then they introduced subsequently the 13-valent vaccine. One of the things that we saw with the introduction of the vaccine is that there was a decrease in the number of invasive pneumococcal illnesses, so bacteremia, pneumonia. However, what we have not really seen is actually, we've seen a decline in the pneumococcal meningitis cases. However, we've seen sort of an increase in the number of cases of pneumococcal meningitis that are not covered by the vaccines. Strains of pneumococcal meningitis that we've never seen before, we're now seeing in the form of meningitis. So it's something to sort of keep in mind because every strain potentially acts a little bit differently. So this is sort of a change from before. Why do we care? Just a quick, I know we all care, but obviously there's a significant morbidity and mortality associated with bacterial meningitis. Deafness, epilepsy, long-term cognitive delays and injuries if it's not recognized early, and then obviously abscess formation and death, to keep in mind. So I know you guys briefly talked about it this morning, but I'm going to sort of quickly mention it here, but the most common causes of bacterial meningitis in neonates, which is your population under the age of 2 months, is going to be E. coli and GBS. Those rates have not changed much since the introduction of all the vaccinations. Does anyone know why? Yeah, you don't get vaccinated until the age of 2 months, so nothing's really changed a whole lot. What are the causes of bacterial meningitis in kids over the age of 2 months? You can just shout it out. Not so much really, actually. GBS has been fairly limited to population under the age of 2 months, but I'm going to give you a caveat. One of the things that we are seeing with GBS meningitis is because of the significant advances we've made in the NICU world, we're seeing preemies, micropreemies live really long lives, and they found that these kids are actually, the risk of GBS meningitis outside of the neonatal period has not changed a whole lot. Nobody really knows why. There's some thought that maybe they're colonized while they're in the NICU, but no one knows why. But it's specifically that population, it's the preemie population that's at increased risk of GBS meningitis, not so much your otherwise healthy term kid that didn't spend time in the NICU. It's true. Strep pneumo, perfect. Anything else? Sure, yeah. What was the last one? Perfect. Yeah, good. Yeah, so those are the biggies. Also to mention, so those are the common, so your strep pneumo, Neisseria meningitis, and your Hib are going to be your common bugs if you're otherwise healthy, older than 2-month-old child. Obviously, we know not all of these kids are otherwise healthy, so you have to sort of think about other pathogens, particularly in these special populations. Kids with BP shunts, kids with cochlear implants, which are becoming exceedingly more common given how kind of well kids are doing with this. So you have to think about staph and Pseudomonas in these kids. You have to have a lower threshold to consider bacterial meningitis in these children, particularly that have had instrumentation. And then some other sort of oddball bacteria to always keep in the back of your mind. Really sort of important for our population because we see a lot of international, our kids really travel internationally a decent amount. They're oftentimes visiting the islands and going back to their home countries. So you have to keep TB, they're a lot of times exposed to farmland, things like that, so you have to keep in the back of your mind things like Leptospira, Treponema, Brucella. So these are sort of not your run-of-the-mill ones, but just sort of keep it in the back of your mind so that you ask for it on history so that maybe it'll raise a red flag for you to think about. And this we talked about, which is that in preemies, the incidence of GBS meningitis beyond the neonatal period hasn't changed a whole lot, and we sort of talked about why that was the case. Let's talk a little bit about the clinical presentation of meningitis, and we'll break it up into sort of the infant, the preverbal, and then the verbal child, because I think they're two very different categories of children to see. So what are some clinical signs and symptoms in infants older than 2 months that would make you suspicious for bacterial meningitis? Sure.
Inconsolable. Inconsolable.
Yes, absolutely. Okay. Lethargy. Good. Yes. Fever. Yes.
Seizure.
Seizure. That was a good one. Anything else? Yeah. How many of those symptoms do you see in your otherwise healthy virally URI kid? Right? So this is where sort of the diagnostic challenge really comes in. We'll talk a little bit more about that. Now let's talk about more signs and symptoms for your older verbal kid, maybe closer to your 10-year-old adolescent child. What are some signs and symptoms in that age group that are maybe different from the ones that you would expect in infants? Anybody? Yeah. What else? Yeah. Alternative status, okay. Someone said whispered something over here. Confusion? Diffusion? Oh, confusion, yes. Yes. Yes, so that is something that I really want to highlight because a lot of these signs and symptoms, altered mental status, confusion, not the easiest to kind of address. Sometimes your febrile kid is just tired and sleepy and then it's 4 a.m. and you're sort of left thinking, are you somnolent or are you just sleepy because it's 4 a.m.? But probably one of the most important things to sort of keep in mind is somnolence out of proportion to what the parent would expect. And sometimes that's not the easiest thing to address. So one of the things that I was always taught is if you're unsure, just watch them. You are in no rush to get them out of the ER. Just watch them. They're going to declare themselves. And better if they declare themselves with you there rather than you send them home prematurely because you think everything's okay. So never feel worried about keeping a kid because you just kind of want to watch them. So I think you guys mentioned sort of most of these altered mental status, bulging fontanelle. Remember, bulging fontanelle, your fontanelles close on average somewhere between 12 to about 17 to 18 months. So that would be a normal fontanelle closure age. If you have a bulging fontanelle in someone outside of that age group, you sort of have to think about other things that are going on because that's not just a bulging fontanelle. Maybe there's an underlying hydrocephalus, maybe there's a mass, maybe there's something else going on, okay? So those are the biggies with this. Let's talk a little bit about, this is probably really important, some common mimics of meningitis. What are some really common diagnoses that we see that should trigger, should I think about meningitis, or what are some common mimics that you guys think about? Pharyngitis, why pharyngitis?
They often will have neck pain and fever,
Absolutely, good. What else? Yes. And what age group do you generally see in RPA? Would you see it in a 17-year-old commonly? Yeah, why is that? Does anyone know?
It's the inflammation of the cervical node.
Yes, that's what P's board studying. Yes. So, big up to Rosie. Yeah, so your retropharyngeal space invalids by about 6-7 years of age, which is why we see RPAs in kids, in younger kids, and older kids we generally see more peritonsillar abscesses. And that's not a hard and fast rule. Not that you cannot get an RPA in someone older, it's just less likely given the anatomy. Okay, what else? What other sepsis, yes. This side's been quiet. You guys give me something. Flu, good. What about not flu season? Migraine. Dr. Khan for the win.
No,
yes.
no.
Oh, sorry. Sorry. Okay, what else? Huh? Sure, but I'm talking about common diagnoses that would make you think about meningitis. Not that encephalitis, it's not uncommon, but it's not common. What are some head and neck things that we see really commonly?
Otitis.
Otitis, yes. And what sort of a complication of otitis that we worry about? Mastitis. Good. Good. Those are the things that I want you to think about, because those are the things you guys are going to be commonly seeing. So I want you to think about, when this kid has otitis, should I be thinking that there's some meningeal involvement? Because a lot of kids with otitis will come in with headache and pain everywhere and don't want to move their neck and are holding their ear like this. So those are the things I want you guys to think about. So perfect. Otitis media, which you guys mentioned, pharyngitis, which you guys mentioned. Other thing is young children with idiopathic torticollis. I know Isaac just did a lecture on atlantoaxial rotary abnormalities, so think about that too. But also think about meningitis. And then RPA, lymphadenitis of the neck, they usually come in sometimes with a lot of pain and discomfort. And then your sort of less common ones, but the things you should think about is substance abuse, migraines, sorry. And then your NMDA receptor encephalitis and things like that. So for ED evaluation, really the take-home point of this slide is always have a really high suspicion for every diagnosis being bacterial meningitis, and your job is to talk yourself off the meningitis ledge, is what I'd say. So any kid I see, I'm like, all right, they look good. I don't think they have meningitis for this, and this reason. Like I said, sometimes evaluation can be hard because symptoms, depending on what time they present, what kind of mood the kid is in, how much the kid has eaten, can also affect your evaluation of the child. So keep that in mind, do what you have to do, but always have a really high suspicion. And remember that an absence of a fever does not make the diagnosis impossible. It makes it less likely, but it's not impossible. So don't sort of say they don't have a fever, so they don't have meningitis. Say if they don't have a fever, but it's less likely that they do, but you still have to prove to yourself that they don't have other signs concerning for meningitis. So physical exam, this is something that we sort of always talk about, rigidity, meningismus. I think this is one of the really sort of, you either have it and it's really helpful, or it's really vague and it's almost unhelpful, which is sort of, I think kids go on either side of the spectrum. I think most of you guys in this room have been in a case where you're like, the kid kind of looks uncomfortable, they're kind of holding their neck like this, but I don't know, because when they're walking around, they're moving their neck. Does that mean they're okay? So, nuchal rigidity is not really that common in infants for obvious reasons. They're not really moving around their neck that much. And even if they are, it's really hard to assess if you kind of touch them and they cry. Is that because they're having nuchal rigidity or they're just annoyed that you're touching them with your cold hands? And it can be absent in older children. So lack of nuchal rigidity does not mean lack of meningitis. Range of motion in the sagittal plane, so looking up and down, has been shown to be probably the easiest test that you can do and sort of something that you can get kids to easily understand. I think Koenig and Brzezinski's may be helpful. I think it's a really hard, for those of you that have tried to do it on children, unless they're a lot older, it's a really hard test to explain to them what to do and to get an appropriate response back and to get something that's useful for you clinically. And the sensitivity of neck findings, remember, range anywhere from 45 to 95%. I don't know. Could be helpful if it's really helpful, but it's not helpful if it's not. So, welcome to pediatrics. But I think range of motion in the sagittal plane is something that most kids fairly comfortably will do for you. Kids that are kind of verbal, you can kind of coach them into it and sort of assess their comfort or discomfort. Skin findings, anytime you're considering meningitis, you have to do a head-to-toe skin exam. Look for petechiae, which can be present in any bacteremia, any severe bacterial infection, but it's commonly seen in invasive meningococcal diseases. And then it is associated with sort of a later course, so if you see it and you're thinking about it, you have to give antibiotics like yesterday, okay? And then other clinical features, more really of shock, which is poor cap refill, and then the blanching rash, which may precede the petechial rash that you'll kind of see. One of the tough things about our population is petechial rashes can be particularly tough to see on African American children, which is sort of like another layer of complexity that adds to this. So rashes are important, but it really is sort of a holistic picture that will really help you make this diagnosis. Okay? Let's look at the rashes really quickly and sort of the progression of the rashes. Usually starts off with more of a petechial rash, which you see these, they're almost like small little red dots. You guys have all seen petechiae. This is sort of the scattered petechiae that's seen in the early stages of meningococcemia. Then there's the petechiae, but then you're starting to see a little bit more of that purpuric rash, which is sort of the next and one of the later stages. And then this is the purpura fulminans that's there in DIC and meningococcemia. This is sort of one of those pictures that I think a lot of us have seen in textbooks, and I always thought when I started practicing, like, I'm just going to see this rash. Didn't get to see it. I don't know if anyone else has seen it, but hopefully I will never see it. I'll catch it when it's petechiae. That's the goal. And then findings that indicate that a patient should undergo LP: fever, neck stiffness, ill appearance, photophobia, severe headache. But like we talked about, all of these can be kind of really vague. But really one of the things to always keep in the back of your mind is excessive somnolence. That kid that is febrile, that's not looking so great, you give them Motrin, you give them Tylenol, and they're just not perking up. That's the kid you really need to seriously start thinking about, is there something more going on? All right, diagnostic studies. What serum diagnostic studies did you guys get in someone that you're considering bacterial meningitis on? Yes. Sure. Okay.
Serum, sorry.
Serum glucose, protein.
Yes. So you have to think about sepsis DIC. So you have to do essentially your basic labs. At minimum, you have to get a CBC, you have to get a CMP, you have to get some coags, and you have to. If you get nothing else, you have to get a blood culture. If you have half a cc of blood in that 3-month-old, and you can't send any other test, send the blood culture. That is probably, if you're going to give antibiotics, don't ruin it for everybody else upstairs. Just send the blood culture, and they could work on a pea stick or something else, okay? Okay. Yeah, so this is sort of what we talked about. So let's talk a little bit about the serum studies. CBC, remember, not all of these kids will have a white count, and a white count is also not a good predictor of meningitis. There's been some really small studies, some sort of anecdotal evidence to suggest that a peripheral neutrophil count greater than 10,000 has been maybe in the right setting, has some association. You should not use this as your, let me do labs and see if I need to do the tap. That is not how this should be going. You should be doing it the other way around, yes? And then your electrolyte studies you have to do, especially because a lot of these kids present with vomiting, potentially diarrhea, decreased PO, so you have to look for electrolyte abnormalities. And hyponatremia potentially secondary to SIADH is always a consideration. And then signs of shock like metabolic acidosis and things like that. And then your last one is your coags, which Ronnie astutely mentioned. You have to get your coags to evaluate for laboratory evaluation of DIC because you are considering sepsis and septicemia. Okay? However, there is no magical blood test that will diagnose bacterial meningitis. So the only test that would really help you is your CSF study. So nice. Only this half of the room has Disney Plus. All right. So your CSF studies are really the only tests that are active. Okay. All right. What CSF findings, not studies, what CSF findings are going to be suggestive of a bacterial meningitis? Yes? High protein, I heard, blood glucose. High or low glucose? Low. Okay, and what else? High protein. What's the other big here? Yes, most important. Right. You have to have all right, so your CSF analysis, as with everything else in pediatrics, is age-based. So, bless you. So you have to look for an elevated white count and an elevated protein. You can also get a low glucose. However, the only thing that is important is your elevated white count, okay? Please look at Harriet Lane for age-based findings of WBCs. It is age-based as with everything else, okay? I mean, if they have like 700 WBCs, it doesn't matter what age, okay? All right, so you've done a tap. You had to try it 3 times because it had moved the first 2 times and you finally got something good. You did a traumatic tap. All 4 of your tubes are pretty bloody. But you know you have faith in yourself that there's some CSF in there. So you send it to the lab. And the lab says, okay, we have faith in you too, so we're going to run this. And you get a CSF study back with, 5,000 RBCs. 300,000 RBCs. Oh, Dr. Khan has even little faith. Okay, all right. What do you do with that information in terms of how do you evaluate your white count in the setting of RBCs? How do you evaluate your protein count in the setting of all these RBCs?
Corrected to CBC.
Yes, what's the correction?
Anti-cough.
Good answer. Excellent answer. Anybody have the size now?
1,001. 1,000 to 1.
1,000 to 1. Perfect. So, I know. So, Liz Shady for the win. However, these are all sort of things that we've all been taught in residency, and it was always sort of, I don't know that I actually ever questioned it. I just sort of assumed that was what it was. interestingly, so the rule is for every either 500 or 1,000 RBCs in your CSF, you're allowed 1 WBC. So you subtract this allowable number from your total WBC count, and then this is your corrected white blood cell count. Or that's what we've been taught. And the 500 or 1,000, it changes depending on the institution generally, and it's usually one person that decides, and then everybody else decides that's what they're going to do. Protein in a bloody tap or traumatic taps cause an elevation in your protein level. These are two big things that you're trying to evaluate. The two of the only things is your protein and your white count, and a bloody tap is going to kind of mess both of those up. So it's been shown that CSF protein increases by about 1 to 2 milligrams per deciliter for every 1,000 CSF RBCs. So it sort of brings us to the next question is, as I was sort of digging a little bit, none of these formulas have been proven to rule out meningitis. So if you have take home point, trust your WBCs without any correction is a take home, okay? If you have 100 WBCs and your corrected is 25, you need to still trust and treat the 100 and really wait till either your gram stain comes back, but ultimately you need to wait till your CSF culture comes back. This is all great and helpful, but for us in the ER, it doesn't change management. If you're concerned and you have an elevated WBC count for age, you give your dose of antibiotics, and you sort of leave it up to the team upstairs to sort of decide whether they want to continue it, which I think most people would continue it for at least about 48 hours until your prelim cultures come back. So one thing to keep in mind is it's good to do it just to kind of have a sense, but always treat your original WBC count, okay? And remember, these formulas are really not helpful when evaluating neonates. So, like I said, moral of the story is the safest option is to treat, particularly for us, it's a dose of antibiotics. And ultimately, the one thing that you really need from your CSF is already set, which is your CSF culture. Okay? And then trust your clinical imaging, your clinical sense. Whatever made you do the tap made you worried enough to do the tap. We don't tap that often. So trust yourself and just treat it, and then it can be figured out in usually 48 hours. Neuroimaging, this is something that actually came up the other day when we were considering meningitis in a patient. Do you guys image everybody where you're concerned about meningitis? No. Okay. Yes, I heard some yeses over here. Yeah. So, yes, so that is the right answer, which is everything in pediatrics, yes, but here are 8 other things to think about before you think about doing this. So, CT is typically not required if you think that this is just a straightforward meningitis case. However, if you have any neurological findings, signs and symptoms of increased ICP, papilledema, any history of recent trauma, neurosurgery, obviously bulging fontanelle, those are all concerns that there's maybe something more going on intracranially and you should image. But remember, your imaging should never delay your antibiotics. Always give your antibiotics first. You have about 2 hours after you give your antibiotics to still do the tap. Even if you don't get to it within 2 hours, give the antibiotics because your patient living is more important than your tap. And do your best to be expeditious, but we all know how things go when we have to do imaging and a tap, and it doesn't happen in 15 minutes like we imagine it does. And then treatment is going to be ceftriaxone for strep pneumo, which is probably still your most common, and then you have to add vancomycin, secondary concerns for resistant strains of ceftriaxone, so both have to be done. Remember, this is for those of you that work at Kings County specifically. I don't know about downstate. Ceftriaxone is considered an emergency medication. So it is available in the Pyxis. This does not need to come up from the pharmacy. It is available in the Pyxis. It is available in 500 milligrams and 1 gram dosages. So if you need 2 grams on a patient, you can order 2 1 grams, or if you need 1,500 or 1 gram and 500. The nurses should and will be able to pick it up. If any of you guys have any issues expeditiously getting ceftriaxone for your patient, please email Dr. Chow or I, because it should not be an issue and you should not get any pushback. Yes? Okay. And then other antibiotics and other medications that are also available in the Pyxis are stuck to the side of the printer. So just go take a quick peek at it, just so you'll have a sense of what's there and what's not there. Okay? And try to order, like, don't order like 1742 milligrams. Okay? Like order something nice so that it's easy to pull and can be good. Okay? And whatever, I know, do not do whatever Epic says. Look at what Epic says, and then you must use our brain and make a nice number so that our life is better and the nurses will not kill you. So, now, looking at all those of you that ordered 14.25 milligrams of Motrin the other day. I saw that. All right, so let's talk a little bit about corticosteroids, to give or not to give. What do you guys do in adults? Good? A lot of murmuring, which is very, guys, let's focus for a second. So a lot of murmuring, which means that there is a lot of controversy, and if there's controversy in the adult world, honestly, it's going to be the same because there's even less data that we have compared to you guys. So let's talk a little bit about it, actually. So there's probably the most useful literature that's available for the corticosteroids in the pediatric population is this 2015 Cochrane review. It was done by Brower and his team. It included children and adults. It didn't really include neonates, which is fine because that's sort of more relevant to our to our presentation. But this Cochrane review actually showed that dexamethasone improved hearing outcomes in children with meningitis secondary to Hib meningitis. In adults greater than 17, steroids appear to reduce both mortality and hearing loss in pneumococcal meningitis, but the benefit is not as clear in children. And I think this is why there's so much sort of, not so much confusion, but a lot of people are sort of unsure about to give or not to give, because the data doesn't really say give, but it also doesn't say not give. So I dug a little bit deeper, and interestingly, the IDSA, which is the Infectious Disease Societies of America, actually recommends giving dexamethasone at 0.15 per kilo for patients in which you suspect bacterial meningitis. And so does the CHOP pathway, and they sort of also refer to the same Cochrane review literature. But you will see that the Cochrane review showed that it really helped the kids with Hib meningitis. As we learned earlier, we don't see that as much because of vaccinations. The effect is, what we really see are seeing more strep pneumo is what we're seeing, but the studies have showed, or at least that Cochrane review showed that we're not really sure if it actually helps or not. So we're sort of on this kind of like do to give or not to give, but it seems like most of the literature and the major children's hospitals are recommending giving dexamethasone. So I think that's an interesting sort of practice change to sort of think about, to consider, because I think when I trained, we did not give it, but it was sort of for the same reason it's probably not going to help. What I do like about the CHOP bacterial meningitis pathway is it actually sort of recommends giving versus not giving based on your CSF gram stain, which gives you a little bit of a better sense of what bacteria you're treating. And across the board, nobody recommends giving it for patients that don't have bacterial meningitis. However, one of the things that becomes really tough is studies have shown that Dex is really only helpful if given right away with antibiotics. So then you're sort of left with, well, the antibiotics are probably already being given or given before you even do the LP, and then it takes another at least 40 minutes to do the gram stain. So do you wait for the gram stain? Do you not? So I think that's something that I think guys are gonna have to sort of think about. And I think the way I think about it personally is if a dose of if there's no major contraindications to dexamethasone and giving it to the patient, I don't know that it's unreasonable to give it. Yes?
I recall that there was an excellent editorial written on this Cochrane that was published.
Oh, okay.
And the editorial said that all the RCTs included in the Cochrane were from industrialized countries where
Yes.
the risk of side effects are less than other countries, and therefore the benefits of steroids have been diluted by this effect. It still has an NNT of 2021, which is not bad, but if you for non-industrialized countries, probably the benefit of steroids is much
Lower.
Yeah.
Oh, much. Oh,
Because the side effect, the hearing loss as a side effect is higher in non-industrialized countries, therefore giving steroids is more helpful
right.
than
Yes.
industrialized.
I actually remember reading this because I think the concern they saw was that usually in non-industrialized countries they present later in the course rather than here where they present usually earlier. So another thing to think about. And then I want to talk about sort of special considerations. Kids particularly over the age of 5. I'm almost done, guys. I know. I'm very good, Nancy. Almost done. Like 5 more minutes, okay? Kids over the age of 5, typically less affected. So if you're seriously considering bacterial meningitis in kids older than 5, you have to really start thinking about like why do they have bacterial meningitis? Because it's not that common. Studies have shown that about 30% of older children with pneumococcal meningitis had a predisposing risk factor, whether it was an anatomic or a immunological risk factor. So anatomic abnormalities, I think some of which Ronnie had mentioned earlier, things like congenital abnormalities, right? So if you have a kid that looks syndromic, that you're considering meningitis and that maybe hasn't had other stuff done or imaging done, you should seriously consider it. So your post-traumatic kids with CSF fistulas, post-surgical kids, your cochlear implants, VP shunts, and then local infections like sinusitis, mastoiditis, all of those are things to consider. Remember, we talked about those earlier in setting up common mimics for meningitis. So always keep that in the back of your mind. And then immunologic stuff, so inborn errors of metabolism, and also congenital kind of conditions like sickle cell disease, CAH, Down syndrome, and then acquired things like HIV, asplenia, diabetes, and sort of renal disease. So last few slides, a couple of take-home points. If you take home nothing else, this is what I want you to guys remember. Bacterial meningitis is a clinical diagnosis. Doesn't matter what all the labs and everything show. If you're concerned about it, do the tap, okay, and give the antibiotics. Give your antibiotics first. You have about 2 hours. Try to do your best, be expeditious, but give the antibiotics first, okay? And then your most common causes in kids under the age of 2 months are going to be E. coli and GBS, and in kids older than 2 months, it's going to be strep pneumo and Neisseria, meningitis. And remember to ask about birth history in these kids older than 2 months, particularly for preemies, because then GBS comes into play if this kid was a preemie or micropreemie. Yes? And then really, kids older than 5, you really have to start seriously thinking about why do you have meningitis? Do you have something else going on that I have to think about? I think that's it.